If you're living with sciatica, diabetic neuropathy, or any type of nerve pain after 60, chances are high that your doctor has already prescribed gabapentin or pregabalin. Maybe you've been on it for months, maybe for years, and now you're starting to wonder why the burning, tingling, and shooting pain hasn't gone away. Even worse, nobody warned you about what these drugs actually do to your brain, your kidneys, and your independence after 60. Gabapentin and pregabalin are classified as anticonvulsants. Developed in the 1990s to treat epilepsy and seizures, researchers later discovered they also reduce nerve pain signaling. Today, they are among the most prescribed medications for neuropathic pain in America. Gabapentin is known as Neurontin, and pregabalin is sold as Lyrica. Both work in similar ways. They bind to specific calcium channels on your nerve cells, reducing the release of neurotransmitters that carry pain signals to your brain. In simple terms, they do not fix the root cause of your nerve pain. They turn down the volume of the signal your brain receives. They mask pain, they do not treat it. And after 60, that distinction is critical. Studies validated by the American Academy of Neurology show that these medications provide moderate to significant relief for sciatica caused by spinal nerve compression and diabetic peripheral neuropathy. For these two conditions, many seniors experience genuine reductions in burning, tingling, and shooting pain. But for other types of nerve pain, including phantom limb pain, post-surgical nerve damage, or fibromyalgia, the benefits are modest or sometimes non-existent. Yet many patients continue taking these drugs for months or years without anyone re-evaluating whether they are helping. Dosage is where the danger escalates after 60. The maximum approved dose of gabapentin is 3,600 milligrams per day, while pregabalin ranges from 150 to 600 milligrams. Both medications are cleared almost entirely by the kidneys, and kidney function naturally declines by about 1% per year after 60. Standard doses that were safe at 50 can silently accumulate at 70, magnifying both the effects and side effects to dangerous levels. Anyone on these medications for more than a year should have their kidney function checked at least every 6 months. If your doctor hasn't ordered a creatinine and eGFR test recently, insist on it. This is non-negotiable for safe long-term use after 60. The most common side effects are drowsiness, dizziness, and fatigue. For a 40-year-old, these might be mere inconveniences, but for seniors, they are catastrophic risk multipliers. Falls are the leading cause of serious injury, hospitalization, and loss of independence in this country. Over 36,000 seniors die from falls every single year. If gabapentin or pregabalin makes you unsteady, slow, or foggy on your feet, your risk of a serious fall skyrockets. Report it immediately. Long-term use brings deeper concerns. Extended use has been linked to memory problems, cognitive decline, brain fog, difficulty finding words, and slower thinking. For seniors already navigating natural cognitive shifts, this is a severe risk. Mood changes, increased anxiety, depression, and physical dependence can also develop, meaning sudden discontinuation can trigger withdrawal, including anxiety, insomnia, nausea, and in some cases seizures. The most serious risk comes when these drugs interact with opioids like hydrocodone, oxycodone, tramadol, or combinations with acetaminophen. Respiratory depression can occur, slowing breathing to dangerous levels. In vulnerable seniors, this combination has caused hundreds of deaths each year, often labeled as accidental overdoses. Every doctor on your care team, internist, pain specialist, cardiologist, must know every medication you take. Keep an updated, complete list. Let me give you an example. Frank, 73, a retired electrician from Indianapolis, came to my office after his wife noticed he was unsteady. He was taking 1,200 milligrams of gabapentin 3 times a day for diabetic neuropathy. Within 6 months, he had fallen twice in his garage, broken his wrist, and became slower and confused. His kidney function had dropped to 45 eGFR, meaning the medication had been silently accumulating. We tapered him off gabapentin under supervision. Within 8 weeks, his balance and mental clarity returned. His neuropathy was addressed differently, safely, without the systemic burden. There are evidence-based natural alternatives that, when combined, can significantly reduce, or even replace, the need for these medications in many cases. The first foundation is specific B vitamins. Deficiencies in these vitamins are not just common in adults over 60, they are dramatically common in seniors taking metformin or proton pump inhibitors. Vitamin B1, thiamine, is essential for the energy metabolism of every nerve cell. A deficiency directly impairs nerve conduction and is strongly linked to peripheral neuropathy. The form called benfotiamine, a fat-soluble version of B1, is far more bioavailable for older adults, crossing into nerve tissue more effectively than standard thiamine. Clinical trials show meaningful improvements in diabetic neuropathy. Vitamin B12 maintains the myelin sheath, the protective coating around your nerve fibers. Low B12 slows nerve conduction, producing tingling, numbness, and weakness. Up to 43% of adults over 60 have low or borderline B12 levels, often without knowing it. The most absorbable form is methylcobalamin, ideally taken sublingually to bypass age-related digestive absorption issues. Vitamin B6 supports neurotransmitter production and nerve repair, but too much B6 can actually cause neuropathy rather than relieve it. Supplement within recommended therapeutic ranges and under guidance. Alpha-lipoic acid, while not a B vitamin, is a powerful antioxidant extensively studied for diabetic neuropathy. Multiple trials show significant reductions in burning and tingling by reducing oxidative stress in nerve tissue. Before starting any of these supplements, test your B12 and B1 levels. Correcting a real deficiency can produce symptom relief rivaling medications without side effects. The second pillar is physical therapy, which is essential, not optional. A qualified therapist specializing in nerve pain can identify specific positions, movements, and postural habits that worsen your pain and teach you how to correct them. For sciatica, spinal position during sitting, sleeping, bending, and lifting dramatically affects pressure on the nerve root. These recommendations are individualized, ideally based on imaging such as MRI or X-ray of your lumbar spine. Knowing which disc is herniated, which nerve root is compressed, and which movements relieve versus worsen compression is far more effective than generic internet advice. Consider Margaret, 68, a retired teacher from Charlotte, who had 3 years of severe sciatic pain. She was on pregabalin 150 milligrams twice a day, which helped, but she hated the brain fog. With targeted physical therapy based on her L4-L5 disc herniation, she halved her pregabalin dose in 6 weeks and stopped completely in 12 weeks. Her pain became manageable through daily decompression exercises and posture correction. We treated the structural problem, not just the pain signal. The third pillar is topical pain relief. While it doesn't address root causes, it can reduce day-to-day symptoms during flare-ups without systemic side effects. The most evidence-supported options for nerve pain are capsaicin and arnica montana. Capsaicin, from chili peppers, depletes substance P, the neuropeptide carrying pain signals. Repeated application progressively desensitizes nerve endings, reducing pain intensity over time. Initial use may temporarily increase burning, but continued application 2 to 3 times daily generally leads to meaningful relief by days 7 to 10, with continued improvement. Arnica montana extract has well-documented anti-inflammatory properties for nerve and joint pain. Use products listing capsaicin or arnica as the active ingredient, and avoid those with synthetic additives, artificial fragrances, or skin sensitizers that could irritate nerve tissue. The most important pillar, often overlooked, is addressing the underlying cause of nerve pain. For diabetic neuropathy, the single most powerful intervention is blood sugar management. No vitamin, no medication, no therapy manages diabetic neuropathy as effectively as controlling chronic high blood sugar. Studies consistently show that maintaining A1C below 7 not only slows progression, but in some cases allows damaged nerves to begin recovering. This is not a supplement recommendation, it is the foundation of effective care. For sciatica caused by lumbar spine nerve compression, the structural problem must be targeted directly. Medication only manages the pain signal. Physical therapy, posture work, Decompression exercises, and in some cases medical interventions, address the compression itself. Symptom management alone does not resolve the underlying problem. The ultimate goal is always to eliminate the source, not just quiet the signal. Some critical safety reminders cannot be overstated. Never stop gabapentin or pregabalin abruptly. Both require a gradual taper under medical supervision. Sudden discontinuation can trigger withdrawal symptoms including anxiety, insomnia, nausea, and in some cases, seizures. Never combine these medications with alcohol, as it dramatically amplifies drowsiness and fall risk after 60. Avoid driving until you fully understand how the medication affects alertness and coordination. If you are taking any opioid medications alongside gabapentin or pregabalin, ensure every doctor on your care team is aware of both. And if the medication does not provide meaningful relief after a reasonable trial, typically 8 to 12 weeks at an appropriate dose, have an honest conversation with your doctor about alternatives. Continuing indefinitely without clear benefit is not a neutral choice. It is exposure to side effects without compensating reward. The bottom line? Gabapentin and pregabalin are legitimate tools for nerve pain. For some patients, they provide meaningful relief, but they work best as part of a broader, holistic approach that includes targeted nutrition, structural physical therapy, topical support, and most importantly, treatment of the underlying cause. The goal is always to need medication for the shortest time possible, at the lowest effective dose, while allowing your body to do the deeper work of healing. You deserve to make these decisions with full information.